Welcome to the Oncology Nursing Podcast. Today's episode is part of our Health Policy and Advocacy series. Nurses are the most trusted profession in the United States and have an important voice in shaping health policy work at the local, state, and national level. These episodes give oncology nurses a chance to hear from the nation's top leaders and gain understanding of how federal legislation is implemented and affects public health. Thanks for listening to the Oncology Nursing Podcast. Morning, and welcome to the Oncology Nursing Podcast. My name is Lisa Kennedy Sheldon from the Oncology Nursing Society, and I am very honored today to have Mitch Zeller, Director of the U.S. Food and Drug Administration's Center for Tobacco Products. Good morning, Mitch. How are you?
I'm fine, Lisa. Good morning.
Good morning. I wanted to just give a brief introduction to set the stage today for our interview. Since 2013, Mr. Zeller has led efforts to reduce disease and death from tobacco use and bring previously unavailable information about its dangers to light. Mr. Zeller is dedicated to leading the charge to reduce the harm from all tobacco products across the entire population, with a focus on how and why people start, stop, or restart using these products. His prior career highlights include Associate Commissioner and Director of the FDA's first Office of Tobacco Programs, the U.S. Delegate for the World Health Organization, and Executive Vice President of the American Legacy Foundation, where he created the foundation's first Office of Policy and Government Relations. It's an honor to have you here with us today, Mitch.
Well, thank you very much. It's a pleasure to be here.
As you know, for oncology nurses, unfortunately, what we see are the most hazardous and dire effects of tobacco use with a number of people that we treat for lung cancer. So this has always been a big, important issue for us, and we often see that, unfortunately, a cancer diagnosis becomes a teachable moment for patients and for families. It's well known that combustible tobacco products such as cigarettes, pipes, and cigars cause more than 85% of lung cancers, and lung cancer would be a rare disease if it weren't for tobacco. Oncology nurses have been instrumental in caring for people with tobacco-associated cancers and encourage and support their efforts to quit smoking, often during those teachable, unfortunate moments. In addition, a cancer diagnosis also can lead to a time when we can teach families about up-to-date information about the hazards of tobacco products, nicotine addiction, and the newer electronic nicotine delivery devices, the ENDs. How has the tobacco control changed since the development of ENDs and the introduction of vaping?
That's a really important question. Years ago when I was out of government and consulting to the pharmaceutical industry and speaking to nicotine addiction treatment experts, long before e-cigarettes came along, they said, if only we could have pulmonary delivery of nicotine without combustion, this would be a great thing for our heavily addicted smokers that we see in clinic. And so fast forward, along come e-cigarette, and we now have pulmonary delivery of nicotine without combustion. There's no tobacco in e-cigarettes, yet this technology has completely divided the tobacco control field because the technology has brought both enormous risk because of the epidemic levels of uptake of e-cigarettes by kids. And those risks, understandably, I think, have obscured some of the potential benefits, especially in a properly regulated marketplace, for pulmonary delivery of nicotine without combustion for the addicted cigarette smokers, especially those unable or unwilling to quit who could completely switch to e-cigarette. But from where I sit, having worked on these issues now for over a quarter of a century, this technology has been mostly divisive. You can look at the public health and tobacco control field and you can see pitched camps with very little interest in establishing common ground. There's one group of people who are ardent anti-e-cigarette, anti-harm reductionists, and there's an equally vocal group on the other side. And those positions are understandable. What I find frustrating is the resistance on both sides to seek some kind of common ground, even if it's just on principles that everybody could agree to. And it leaves those in the field like oncology nurses with a lot of questions of what are we supposed to say to patients who, unfortunately, you're only seeing them because they're in the hospital, and they might have questions about e-cigarettes in as you described, this teachable moment. The answer that I would give is, look, if you're concerned about your health and for whatever condition you've come down with, you're now willing to revisit your smoking status, there are FDA-approved medications, prescription and over-the-counter, that can help you, which when coupled with counseling can more than double your chances of quitting. A lot of patients are likely to say, I've tried everything. None of it has ever worked for me. What about e-cigarettes? And I think the only sensible thing to say to them in that setting is they are not approved by FDA as cessation aids. There is anecdotal evidence that e-cigarettes have helped some smokers switch. But the reality in the real world is most e-cigarette users continue to smoke. And it is yet to be seen that there's any benefit to someone who is using e-cigarettes if they continue to smoke regular cigarettes. The only potential benefit would come if you completely switch. In the meantime, there are these other FDA-approved medications that you might want to think seriously about using.
Those are really interesting comments and also great communication strategies. Having been trained in a tobacco treatment program years ago at the University of Massachusetts at the medical school, I was struck by the fact that we have medications and often we don't have patients who are either willing to try it or feel like it won't work for them. And I think that's great advice, is to think about what are the reliable evidence-based approaches that we can be using and recommending to our patients.
And one more thing to add about pharmacotherapy is one of the reasons why things like the nicotine gum patch and lozenge don't work as well in the real world as we would hope is related to compliance. So this becomes another teachable moment. It's not just, would you consider using these medications that don't even require a doctor's prescription? It's making sure that they are taking enough of it and using it long enough to have an impact. Unfortunately, when it comes to the pharmacokinetics of these products, they don't deliver the nicotine nearly as fast as a cigarette or even an e-cigarette. You have to be really committed, have to be talking to your doctor or healthcare professional and explore things like combination therapy, where you're using, say, a patch, which will provide a continuous, albeit low level of delivery of nicotine all the time. And in consultation with a healthcare professional, you could also be taking an oral form, gum or lozenge. And then when you combine that with counseling, now you're talking about having a real chance of quitting.
Yeah. And now we certainly have more opportunities to be using telehealth and counseling to be supporting either the pharmacologic or non-pharmacologic methods for quitting smoking.
Right.
I know the center's been instrumental in leading the effort to curtail the marketing and distribution of tobacco products to minors. Now we've seen a 2-decade decline in tobacco smoking. We have significant new issues with nicotine-containing products, as we're talking about that pulmonary delivery system, unfortunately, in the ENDs or e-cigs. How does the center differentiate between tobacco products and nicotine-containing products used in ENDs?
Well, there's sort of like a bureaucratic legal answer, and then there's more of a real world public health answer. Legally, and this will sound counterintuitive, legally, e-cigarettes are tobacco products under our statute, the Family Smoking Prevention and Tobacco Control Act. And that's purely a definitional thing. The statutory definition of a tobacco product is anything that is made or derived from tobacco and intended for human consumption. The nicotine in e-cigarettes is derived from tobacco. Just to go back to our last conversation, so is the nicotine in gum patch and lozenge. It's all derived from tobacco. I make that point because the real world public health issue here is it may meet the statutory definition of a tobacco product, but when we look at the death and disease caused by tobacco use, which is primarily firsthand and secondhand exposure to cigarette smoke, the cancers that you and your colleagues are seeing in hospital, and the lung disease and the heart disease is not directly caused by the nicotine. I'm not saying that nicotine is a completely benign and harmless substance. The nicotine likely got the smoker hooked at a very young age. The smoker then winds up smoking for decades and has to be admitted to the hospital for some kind of treatment. The cancer and the lung disease and the heart disease that occurs over time is not directly caused by the nicotine. It's caused by other compounds, principally in tobacco smoke, not even in the tobacco, but there are carcinogens in the tobacco as well. It's why we have to take a more holistic look at nicotine across what we call the continuum of risk. Yeah, e-cigarettes are tobacco products in the same way that cigarettes are for the definitional reasons. But there are more harmful and less harmful ways to deliver nicotine. And the least harmful way is the medicinal products. They're not completely safe, but on a continuum of risk, gum patch and lozenge are the least harmful way to get nicotine. And at the other end of the spectrum is the conventional combusting cigarette or cigar. And we need to account for these relative differences in risk because with all the progress that we've made in reducing consumption and prevalence of cigarettes over the last half century, going back to the first Surgeon General's report in the mid-1960s, we're still talking about the leading cause of completely preventable disease and death in the country and in the world. And the conservative estimate is, with everything that's going on with COVID today, and I'm not making a comparison, but there is a reality here. Year in and year out, conservatively, tobacco products kill 500,000 Americans a year. And there's almost an epidemiological irony, if you will. At the time of the 50th anniversary Surgeon General's report in 2014, when the Surgeon General was able to look back over the first 50 years and say, wow, tremendous progress. We went from an adult smoking rate at the time of the first report of 44%. Almost 1 in 2 adults in the United States smoked, to, at the time of the 50th anniversary report, a 2/3 reduction. At the time, 15%. We're probably down to now 13%. It's still the leading cause of preventable disease and death. And the irony is, at a time when consumption and prevalence is going down, the list of tobacco-related diseases has gotten longer, which is why the annual death toll is now higher at a time when consumption and prevalence is down. So we have our work cut out for us. And as public health professionals, we need to look with an open mind towards this continuum of risk and the possibility that in a properly regulated marketplace, even an e-cigarette could have a role in helping some smokers quit, as long as the switch to e-cigarettes is to exclusive use. Again, if you continue to smoke while vaping, there's likely no benefit.
Yeah, I think that's a fantastic message for our listeners, is that it has to be the exclusive use for quitting smoking. And we often see people who, have extensive smoking histories, many pack years histories, have a lung cancer diagnosis. And there's a great deal of shame, actually, for some of them. And sometimes the messaging in the counseling is the nicotine in those cigarettes that got you addicted, was done when you were young. And I'm worried now about that addicting substance in the ENDs. Is there as much nicotine in the ENDs as there is in cigarettes? Is it a dosing equivalency? There seems to be some variability in the content of nicotine in the vapors that are used in the ENDs. Could you talk a bit about that?
There is no one e-cigarette. There is no one ENDS electronic nicotine delivery system product. As you said, the nicotine levels, the nicotine doses can vary dramatically. So let's start with the product that everybody has heard of, Juul. And in what remains an epidemic when it comes to kids' use of e-cigarettes. So everything that I said about e-cigarettes for addicted adult cigarette smokers, let's put that aside. No kid should be experimenting with any nicotine-containing and nicotine-delivering product, whether combustion is present or not. We're talking about the still developing adolescent brain. We're talking about a great risk of addiction and the possible transition to even more harmful products than e-cigarettes if a kid experiments with an e-cigarette. But to this question of nicotine levels, Juul, at the 5% nicotine strength that is available, one Juul pod can have as much nicotine as an entire pack of cigarettes. One Juul pod.
Wow.
And the reason why we are so concerned about that is from the qualitative and quantitative research that we've done to inform our public education campaigns. For the last 2 years, we have invested hundreds of millions of dollars in all manner of paid media in every medium to get the word out to kids who are walking around with profound misperceptions about e-cigarettes. They think they're harmless. And a bunch of kids who are vaping make the mistaken assumption that there's no nicotine present in their products. Why they make that assumption, we don't know. But there are a lot of kids who equate e-cigarettes with a harmless experimentation. Kids that never would have tried a cigarette because they know that cigarettes are dangerous are open to experimenting with e-cigarettes. So we are trying to get the message out to kids through TV, radio, social media, internet, gaming sites. Wherever kids are consuming media, we're getting the message out that there are some harmful compounds in the vapor of e-cigarettes, some of the same harmful compounds that can be found in cigarette smoke. Again, for the addicted adult smoker who switches, there's going to likely be a reduction in risk. For a kid who is thinking of experimenting, all there is risk. And the National Academy of Sciences a couple of years ago was able to conclude that if you take a group of kids who never would have tried any tobacco product, a cigarette, a smokeless tobacco, an e-cigarette, from that universe of kids that we call closed to using a tobacco product, a kid in that population who experiments with an e-cigarette, who might never have thought of experimenting with a cigarette, winds up being more likely to experiment with a cigarette after experimenting with an e-cigarette. So we have our work cut out for us here. And we're doing everything that we can with paid media. We have a remarkable collaboration with Scholastic for oncology nurses who want materials and more information at our website, the CTP, Center for Tobacco Products website at FDA, and at the Scholastic website. There's free downloadable information, posters, all kinds of information to get the word out to parents, to get the word out to kids. we've done a pretty good job of helping kids understand that cigarettes are dangerous. We have a lot more work to do to break through and dispel this misperception that e-cigarettes are a cost-free proposition from a health standpoint.
Yeah. It's interesting. I was even thinking, as you were just saying, the Center for Tobacco Products, but it's actually tobacco and nicotine products. So somehow we, in separating those out and understanding the mechanisms for those as well as for the ways that they're delivered is really important for nurses to understand and to be able to communicate with their patients. Because, I'm so worried that we're going to start again with this nicotine addiction in the young people, and 30 years from now, see them back in as patients again from whatever products are in their vaping liquids, that they're inhaling at this time. And also a different tilt here, and I'm going a little off track here because I think it's relevant. We have adults now who have been tobacco smokers for decades coming into our lung cancer screening programs. And they'll come out of their screening, their spiral CT, and they say, well, it's negative, and continue smoking. How can we intertwine both our lung cancer screening programs with tobacco cessation programs so that they're more strongly linked and could have more impact?
It's a really important conversation that the tech, the nurse, the doctor needs to have with the patient. I don't know how comfortable in that situation the professional would be prepared to make an analogy to Russian roulette. But that's what we're talking about. Okay, you dodged the bullet here. Are you going to go back and continue to smoke? Because you need to understand that the cigarette as we know it will kill half of all long-term users prematurely later in life. You don't have a problem today. That's not to say that whether it's lung cancer, another kind of cancer, heart disease, lung disease, that you have a clean bill of health. Are you willing to take that risk? And it's an important and needs to be discussed more sensitively than I just laid it out. But from all the smokers that I've spoken to over the years and all the treatment experts that I've spoken to over the years, chances are the smoker that you have the opportunity to have that conversation with has some degree of concern about their health and some interest in quitting. You made a really important point earlier about the shame and the guilt that smokers walk around with. And that is huge. And the shame and the guilt is even greater if, as we typically see, someone who has gone back to smoking has tried unsuccessfully to quit 5 times, 10 times, 15 times, 20 times in their life.
Yeah.
And so in addition to the shame and guilt of being a smoker, dealing with friends, dealing with children, family members, there's in their mind the shame and the guilt of the failure. They view it as a failure that they wanted to quit. They tried many times and they were unsuccessful. So one of the insights that we've developed there and another resource that we can make available through your organization to the nurses is a campaign that we call Every Try Counts. And there are, again, materials available online. Think of the words, every try counts. A positive message of modesty. It's, look, every try counts. We know that statistically, every subsequent quit attempt you make, even if that individual attempt is not successful, statistically makes it more likely that you will eventually succeed. Every try counts. And we need to figure out ways to motivate and encourage the health-concerned smoker to make the next quit attempt and surround them with all of the support, both professional, pharmacological, emotional, that we can. And they need to be reminded of there are some inescapable facts here. And I'll just go back to that first fact that I mentioned. They are the only consumer product in existence that, when used as intended, will kill half of all long-term users prematurely. That's an inescapable fact.
And that's a shame. That's a shame.
Yeah.
And that's a good thing to know. And thanks for the positive message, both in the title and how we talk with patients, because there are those times I feel they feel like they failed. If I can't quit, and you remind them that it takes many people multiple times. And the title of your program is perfect. Every quit counts. I do want to, while we have time, also want to pivot to what's first and foremost in everybody's minds right now is COVID-19. And we've been reading more about not only the effects of COVID-19 on lungs, but the effect of COVID-19 on the lungs of people who have been smokers.
Right.
And this being also a teachable moment. Could you talk a little bit more about that?
Yeah, we're getting lots of questions from the media, from all interested parties on what is the state of the evidence as regards cigarette smoking and vaping on COVID. Here's what we know. Importantly, there are things that we don't know. We know that if you are a current or former smoker, you are at greater risk of more serious consequences if you contract COVID because of the damage that may already have been done to your respiratory system from the decades of smoking. Sadly, even if you had managed to quit, but certainly if you are a current smoker. So no question, you're at greater risk of serious consequences given smoking status. We are using COVID as an opportunity to get the message out that there has never been a better time to try to quit. Never. And again, most smokers are concerned about their health. Most smokers are interested in quitting. And we are all walking around fearful of contracting COVID, whether we are a smoker or not, and the possible outcomes. So it's an enormous opportunity to have a conversation with a smoker about there's never been a better opportunity to quit. So we know the damage that smoking causes to the respiratory system and that if you're a current or former smoker, you come down with COVID, you are at greater risk of a more serious consequence. We don't know the direct impact of vaping on the risk of either getting COVID or having a more serious outcome. We simply don't know. What we do know is, to go back to a point that we've been discussing already, most people who vape are current or former smokers. Not a lot of people who never smoked become regular e-cigarette users. A bunch of them may have experimented with e-cigarette for whatever reason, but most of the adult e-cigarette users out there today are current or former smokers. So the risk that they may have either of getting the virus or having a more serious condition as a result of it could be because of their smoking status, as opposed to what's going on with vaping, because we simply don't have the evidence that vaping and what's in the aerosol is directly connected to your risk of getting the virus or a more serious outcome.
Yeah. So I know we're getting to the end of our time. And so I wanted to ask you on that note, because I think COVID is giving us an opportunity here to ramp up how we talk with our patients about stopping smoking and about the dangers of smoking. And it is, talk about another teachable moment. We're in it right now. In what ways can nurses phrase their conversations in teaching any patient and their family about the dangers of not just tobacco, but ENTs during the pandemic? I think it's a timely message we can be using to help educate our patients.
Yeah, it's a really important question. And if I were having that conversation with either with a smoker, a vapor who, let's assume, was either a current or a former smoker, or a friend or a loved one of one of those individuals, what I would say is, look, if you're vaping, I can't tell you that by vaping, you're putting yourself at greater risk of getting the virus or having a more serious outcome. But if you are a vapor that is still smoking, or if you were a former smoker, there's a possibility that you could be at greater risk. And really the best thing to do is to stop using all of these products. If I was having a conversation with a smoker, I would be stronger. And I would say, look, you know that you are engaging in a risky behavior. Chances are you've tried to quit. I don't know how concerned you are about your health, but we're all concerned about COVID. And because of your smoking and because of the possible damage that's been done to your lungs and to your respiratory system, I'm not trying to scare you, but were you to get COVID, you could be at greater risk of a more serious outcome. We know you don't want that. We know that your friends and loved ones don't want that. And there are wonderful tools and resources available to you. And there's never been a better moment with this pandemic surrounding us to make the next quit attempt and to be really motivated. And then I would just march through what those resources are and make sure that especially the smoker understood that there's not just one magic intervention. It's not just one type of drug or one type of counseling, that if you speak to your healthcare professional, you will learn that there are things that you can do in combination that give you an even better chance of succeeding in that quit attempt. And it's really important for the friends and the loved ones especially of the smokers, to get the same message as well. Just one other anecdote from when I consulted to the pharmaceutical industry on cessation. One of the reasons why the nicotine patch was sold in a clear form was because the industry had learned from their research the shame and the guilt that smokers were walking around with. And one of the reasons why the patch was sold as a clear form was so that its use could be even more discreet. So the smoker would feel more comfortable walking around with the patch because it would be less likely to be seen by friends and coworkers. That's the degree of shame and guilt that we are talking about, that it actually influenced product design. And so the conversation with the smoker is a very sensitive conversation that needs to be filled with compassion and empathy and understanding, but also information. And I would say, in an appropriate way, a bit of a challenge. And I know that you all know how to have those conversations with your patients.
We've been, I think the beauty of nursing is that you, especially in oncology, is you get to spend a lot of time with people. And previously, pre-COVID, with their families as well.
Right.
But they're often on the telephone calls now. So the telehealth calls are the beauty of some of that is you often get the family in the room at the same time. So you do have the opportunity to keep both patients and families. But because of just the sheer amount of time we spend with people, we hear their concerns. We hear those feelings of shame and guilt, or I wish I could, or I tell my kids not to do it, or I make sure I always go outside so they don't see me. And so you have to, it requires some sensitivity to what they've been through. I don't think most people say, I'm just gonna smoke until I die. I don't hear people say that. They don't really want to continue, and they would like to quit, but they feel like they can't. So you've given us some really great strategies on how we can do that. And I think some of the telehealth support that has been available in the past, and I think, frankly, the tobacco cessation groups have been very ahead of their time in offering those services for, over a decade now. Gives people that ongoing touch point, because it takes time to get off of nicotine. And that's the other part, I think. It's not just the sensitivity, but as you say, the challenge, right? Because you have to be a little persistent. You have to be factual and sensitive, but you also have to be able to do it again and again and again and again. And so that, bringing it up every single time may sound a bit like nagging on the side of the nurse or any healthcare provider, frankly. But it's that persistence, I think, that helps them understand this really is an issue.
There's also pure addiction and pharmacokinetics in play here. The cigarette is ingeniously designed to deliver the nicotine to the nicotinic receptors in the brain in less than 10 seconds. From the time you puff on a cigarette to the time that nicotine makes its way through the pulmonary system into the bloodstream, basically to feed those receptors in the brain that are seeking their next dose. And the receptors don't know from where the nicotine is coming from. The receptors are signaling the body, you are about to go into withdrawal if I don't get my next dose of nicotine. And the genius, if you will, air quotes, of how a cigarette is designed and the potential with e-cigarettes, the nicotine gets there in less than 10 seconds. The challenge with oral and dermal form is obviously it's much slower. It could be 20 minutes, 30 minutes. 60 minutes. Well, the smoker's already out on the street smoking a cigarette at that point because they can't wait that long for the next dose. That's what you see when the smoker is huddled in the rain or in the wind. They're responding to a chemical message that the receptors in the brain have said, which is, I need my next dose. And until e-cigarettes came along, the fastest way, I'm not saying the best, but the fastest way to get it was from burning tobacco leaves and inhaling that smoke into your lungs. But if you do the gum and the patch together, so if you have a continuous delivery of nicotine, albeit at low doses, from a dermal form, and you're talking to your healthcare professional and you're taking gum or lozenge ad hoc as needed, and you're engaged in a counseling program, you can hopefully deal with those nasty receptors that are used to being satisfied very quickly because of how the cigarette has been designed. And if there is an appropriate way to be able to make the switch completely to e-cigarettes so that you can reduce your risk, that's a conversation that the vapor needs to have with their healthcare professionals. But the reality is that is not yet an FDA-approved cessation aid, nor is it recommended by the Preventive Services Task Force.
Oh, those are great advice. I do want to switch a little bit. We are increasingly worried about these flavored vaping liquids, and I know there have been recent controls on that. And we know that those are probably available in Tutti Frutti and bubblegum to appeal to a different generation. Can you talk to us more about what's happened with flavorings and the END liquid?
Sure. Obviously, it's one of our great concerns when it comes to what we have called an epidemic of kids' use of e-cigarettes. They go in search of the flavors that are the most popular with them. And as a regulatory agency, we need to follow the regulatory science. And so the guidance that we issued in January of this year was based upon the most currently available data that we had, which was from the national surveys from 2019 of middle school and high school age kids. And what the 2019 data showed was that kids greatly preferred products like Juul, not just Juul, but products like Juul that are what we call cartridge or pod-based products. And we know they like the fruit and the candy flavored. But for the first time, we had data that differentiated mint from menthol. And there are a lot of people in tobacco control and public health that were not happy with where we drew the line. But for the first time, we had data which showed that at least in 2019, we will be following the 2020 data to see if there are any changes. But as of late last year, when kids were given an opportunity in these surveys to answer preferences for mint separate from menthol rather than combining mint and menthol in the same question, turns out that kids greatly preferred mint to menthol. And so we felt that we had a balancing act to do, to go back to what we've been saying about the potential role that e-cigarettes could play in helping switch smokers to e-cigarettes. And so our January policy said, if you are a flavored cartridge or pod-based product, other than tobacco flavoring, which is not popular with kids, and menthol, which at the time the data showed was not popular with kids, but for all other flavors, those products needed to come off the market. And the only way that they could come back to the market is on what we call a pre-market basis. A company submits an application to FDA, and we decide whether the evidence is sufficient to warrant authorization of a product on a product-by-product basis. But we will follow all of the evidence in 2020, and if there is any kind of migration, we will take appropriate action.
That's fascinating that the kids don't like the tobacco flavor or the menthol. That's a great approach to take to sort of limit the availability of some of these more, well, I would say more, adolescent sort of flavors.
It does, at least based upon the 2019 data. Again, we will see if anything changes in 2020. Yeah. It does help us achieve that balancing act because it preserves adult access to other flavors in the so-called open tank systems. So you go into a vape shop and you spend a much larger amount of money on a device, and it's sort of like the razor blade model. You buy the razor once, you go back and buy the replacement blades. You go back to the vape shop or you go online and you buy your replacement e-liquid flavors. Those products should not be sold to kids. We now have a federal minimum age of 21 to reinforce that these products should not be sold to any young person, but they are available for adults, and those open tank systems are not popular with kids. If the evidence changes and takes us in a different direction, then we will take a look at that.
Oh, Mitch, this has been a fascinating discussion, and I've learned a lot. I thought I knew a little bit from having gone through the counseling program, but I learned a lot more today. And it's really evolving right now, what's happening with tobacco and nicotine-containing products, and this has really been informative. I want to thank you for your time with us. I know oncology nurses are going to really value this podcast and the ability to hear from you and the center about what you're doing and the ways to communicate about tobacco, about e-cigs, about vaping, and maybe start to see a change happen with their patients and families. So thank you very much for your time today.
Well, thank you, Lisa. And let me just say that you folks are heroes. Unfortunately, I've had to have a lot of interactions with oncology nurses and dealing with family situations. And as far as I'm concerned, day in and day out, you're dealing with a lot of death. And as a lawyer, not as a medical professional, I don't understand how you all do it. And to me, you are all heroes because you're dealing with some very, very, very sick people, a lot of whom are not going to make it out of the hospital. So I just want to say on behalf of FDA, on behalf of the rest of us in public health, thank you and thank your organization for doing what you all do. And if this information makes it easier and better for you all to have those important teachable moment conversations with patients and family members, then this was time very well spent. So thank you.
Well, thank you for those kind words. And absolutely, this is so valuable. And I hope you stay well and stay healthy. Thank you, Mitch.
Thank you. You too. Take care.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you download your podcasts. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org.